So welcome everybody. Thank you for your time this evening on a Wednesday evening. My name is Kath Maloney. I'm the CEO of SARRAH, and I'm joining from Ngunnawal and Ngambri country in the nation's capital. And I will take this moment to acknowledge the Ngunnawal and Ngambri people as the traditional owners of this land that I am sitting on this evening, and pay respects to elders past, present, and emerging. We are very pleased to have been working with Karen on this piece of work. Well, Karen's done all the work, but it's been great to be part of this project. And just while people are joining, I'm sure that Karen needs no introduction, but I'm going to provide one anyway. So Karen's an occupational therapy academic at Charles Sturt University and a PhD candidate at Western Sydney University with over 20 years' experience as an occupational therapist. Her work is driven by a strong commitment to fairness and equity, shaped by first-hand experience of the challenges rural people face in accessing care. Karen's research focuses on rural health, workforce distribution, and spatial justice, using national data and mapping to make visible where access to occupational therapy breaks down and why. Through her teaching, research, and advocacy, she works closely with rural communities and organisations like SARRAH to ensure that where people live does not determine the care that they receive. So thank you, Karen. Welcome, and I will hand over to you.
Okay, thank you everyone for having me today. And I'd like to acknowledge the Biripi people on whose land I live and work, and thank them and the elders past and present for caring for country here, and welcome any Aboriginal people who are here today. So just to get the elephant out of the room, I haven't been in a bar fight. I just had a mole removed today, so hopefully all that'll be fine in the long run. But yeah, apologies for my interesting look tonight. But I am going to talk through some of the work that we've been doing on access to occupational therapy services across Australia. And we've been looking at where access is strong, where it's weak, and who's most likely to miss out. And this work sits at the intersection of occupational therapy practice, geography, and policy. And it was done very deliberately with SARRAH in mind to support the advocacy with credible national evidence for all the great work that SARRAH does every day. So before I go any further, I also want to acknowledge the people behind this work. So Simon McDonald, who is an extraordinaire from our spatial analysis network in Charles Sturt University, who did much of the heavy lifting in teaching me to use some complicated systems and working with me to do the spatial modelling. And also Ros Bai, who's here today, who's my primary supervisor for my PhD study from Western Sydney University, with Christy Coxon and Liz Thayer, who I think are also here, as my co-supervisors. And of course, I want to thank SARRAH as well, not only for funding the APRA data that allowed me to do this work, but for creating space for this work to exist and to be used. So I just wanted to quickly start with the idea of spatial justice because it frames everything that follows in this presentation. So spatial justice is a concept from geography that considers that everyone's experience of justice is place-based. So where you live materially influences your access to support and services. But more importantly, your geography isn't just a neutral background where services happen to be delivered. It's actually something that we can change. So the way places look, who lives where, and what services exist are the result of social and policy decisions that have been made over time. And that means that measurement and mapping really matter. What we choose to measure and how shapes what problems we see and which ones stay invisible. And so importantly, policy decisions can make a really big impact on access, even when they seem small or technical on paper. And so the immediate trigger for this work was the change in policy at the NDIS to the travel funding that happened in July 2025. So you're probably all aware that the funding cap for travel was halved, and it only applied, sorry, to allied health. No other professions. It was OT, physio, and speech that it applied to. So on paper, it might have looked like a bit of a tidy budget decision, but in practice, it's not going to be neutral. Travel is a much bigger part of service delivery in rural and remote places, so we were really concerned that those communities were almost certainly going to feel the impact first and hardest. And for occupational therapy, this is especially problematic because our practice is fundamentally place aligned. So we need to see people in their homes or their schools or their workplaces to do our jobs properly. Travel isn't an optional extra, it's part of our clinical care. So the core reason for doing this work was simple. We needed to show who was likely to miss out from these kinds of policy decisions and where that will happen. So rather than putting forward hunches, we could put forward the hard data to influence the way policy was written. So the first step was a very basic but important question. How many people in Australia live more than 30 minutes from any occupational therapist at all? So to do this, we used AHPRA workforce data from December 2024, which was the most recent data that we could get. And that was the data that was funded by SARRAH. And we plotted the location of the OTs in each town or suburb because, again, we could get the data only down to the suburb or town name, not the exact street address for occupational therapists because that was considered too private. So all the pink dots that you can see on the map here are where there was at least one OT. So then we mapped the census 2021 population data at a level called Statistical Area 1 or SA1s. So if you look here, you can see all these grey shapes. They're the statistical area 1s. So each SA1 contains 200 to 800 people with an average of about 400. So we're getting really, really granular at that point. So in a city, an SA1 could be just like one apartment building or a few streets. In towns, it tends to be there may be 3 or 4 in a rural town. And in rural places with less concentrated populations, it might contain a couple of clusters of populations in the one SA1. But it's the smallest area that we can actually get from the Australian Bureau of Statistics that contains details about the populations within it, because once it gets smaller than that, it's a bit too easy to identify people. And there's actually legislation around the census to prevent us from being able to do that, which is a good thing. I don't really want people to know exactly who I am, where I live, and the level of data that goes into a census. So then we used our mapping software called ArcGIS, and we traced the real road travel times. So those are the green squiggly lines on this map. So we actually used an algorithm called fastest route and found the fastest route to the closest occupational therapist. So this is already a big deal as it moved us beyond simple workforce counts and started to tell us something about the lived access of people in Australia. And so from that piece of work, we found out where Australia's OT deserts were. And what we found was pretty stark. So more than 550,000 Australians had no OT within 30 minutes drive at all, and 93% of those people lived in rural or remote Australia. And in very remote communities, nearly 2/3 of residents had no access whatsoever to an occupational therapist within 30 minutes. And we also saw a very clear socioeconomic gradient and a particularly concerning pattern for First Nations communities. And one of the findings, nope, I'm going to skip that. I'm going to come back to that in a minute. So we're seeing clear OT deserts where the system simply isn't meeting the need. And it may be that people in these areas are having fly-in, fly-out access or something like that, because we are only measuring road travel time. They may also be using telehealth, but as I said at the beginning, for a lot of occupational therapy practice, you just simply can't do it. by those means. You need to have relationship with people in a lot of communities to be trusted, to be allowed into their home in the first place, and you need to be able to see what's going on in that person's home to be able to provide that occupational therapy service that we need. But of course, there's still a problem with that data, because distance on its own isn't the whole story. Just because there's one OT within reach of your community doesn't mean that they actually have capacity to take on clients. So a town with one OT and thousands of potential clients doesn't have the same access as a place with several OTs and fewer people. But this distance measure that we were doing treated them as an equal. So that was a problem that we needed to address. Potentially the access was actually better or worse depending on the number of OTs that were around you. So we went back to geography and looked for a new way to actually measure this. And so we came up with using, it's a mouthful, enhanced two-step floating catchment area analysis. And from now on, I'm going to call it E2 because it's a mouthful. So E2 is really cool because it creates a catchment for every single OT, and that catchment floats around them. So starting from the OT's location, it measures the travel distance around them to all the SA1s that they can actually reach. And we aligned that catchment area with NDIS policy. So we said that that travel distance could be 30 minutes in modified Monash levels 1 to 3, or it could be 60 minutes if they were traveling to modified Monash levels 4 to 7. So it was where they were traveling to, not where the OT was based. So if the OT was based like here in Port Macquarie, which is a modified Monash 3, but they were traveling out past Wauchope to modified Monash level 4, they got 60 minutes for that particular trip. So that's really important because that reflects the current funding assumptions within the NDIS travel policy. And so that gave us an accessibility index that can tell us more than just whether there's an OT nearby. Because the catchment actually floats around the OTs, if those catchments overlap, then the accessibility index in that little SA1 that they're overlapping on multiplies up. If the OT's floating catchment covers more than one SA1 area, the OT is divided amongst them based on the population counts in that SA1. So each population group gets a portion of that OT. So that really tells us how much capacity there is in the system. And then it adds one more really cool step, which is applying a decay weight. So closer OTs get weighted more highly than those that are further away. So if there's someone who's 20 minutes away from an SA1 that is in the higher modified Monash levels, they will get a higher weighting than someone who's, say, 50 minutes away, who still has a catchment that covers that area, but it's a bit further for them to go to get there. So in the end, we get the access index, which is a number between 0 and 1, so a really long decimal for every single SA1 in Australia. And so that's our accessibility index. So now we're starting to compare apples with apples a lot more because we know how much supply we have, what the demand is, what the travel times are, and we're applying those decay weights as well to get that index. It's a very complicated equation, but I'm not going to show you because it makes me feel faint looking at it, but it exists and it's in my papers if you ever want to read one. So what did we actually find with this approach? Well, we found that more than 5.7 million Australians had low, very low, or no reasonable access to occupational therapy within those parameters. So like I say, they could potentially have other ways of accessing OT, but within these parameters, these were the outcomes that we got. And so then the next question is, who are these people? Who's the most affected? So this is a complicated slide, but across the top, because our numbers were so ridiculously small, like little tiny decimal numbers for our access index, we broke them into 6 categories, and we did that using logarithms and a complicated equation, which again I can show you if you're excited about that kind of stuff. And we broke people into whether they were nil, very low, low, medium, high, or highest level of access. So interestingly, Brisbane is the place to be if you want lots of access to occupational therapists. That must be the home of occupational therapy or something. Lots of people in Brisbane. And so you can see that in metropolitan areas, so this is our modified Monash levels of remoteness, you can see that it tended towards the medium, high, or highest level of access in those areas. My dog's trying to say hello. But you can see the amount of people with no access increased with remoteness, and the amount of people with high access decreased with remoteness. But again, fascinatingly, well, not fascinating, probably quite expectedly, in level 4, where it jumps, remember, from 30 minutes to 60 minutes in our NDIS rules, suddenly access jumps back up again, which is why it's so important from a spatial justice perspective to think about the impact of what seems to be a fairly arbitrary decision, like 30 minutes, 60 minutes. I'm not entirely sure where those numbers came from. They seem very rounded and most likely just seemed like a fair enough thing when the policy was written. So our remote communities, though, very, very remote communities, 64%, so more than 2/3 of people in remote communities had no access at all to an occupational therapist within 60 minutes drive, because we now were applying those 2 levels. Type of community that you lived in, though, also mattered. So we used what's called the Index of Relative Social Advantage and Disadvantage, or the URSAD, which is an ABS, an Australian Bureau of Statistics measure that looks at socioeconomic status. So it uses a bunch of census results like car and home ownership, employment status, type of employment, income, and so on, to develop an URSAD score for the entire SA1 area. So it's not an individual score, it's for the whole area. So each SA1 is given this score, and low scores relate to higher relative disadvantage, and high scores relate to higher advantage. And so those scores are placed in a decile from 1 to 10, again with 10 being the most highly advantaged areas. And you can see that there is a very clear pattern just in these basic statistics showing that people in those higher deciles of URSAD had much better access to occupational therapy than people who were in the lower deciles. They were more likely to have no access or low or very low access. So we're talking about people who have the least ability potentially to self-fund or get themselves to an occupational therapist if they needed it. So we also did some regression modelling, which isn't in the paper that we provided for the policymakers. It's actually in another paper that I've submitted for peer review recently. And so population size and URSAD were both positively associated significantly with access. So our access index, if you had a high access index, you were more likely to be more advantaged. And if there was lots of people there, like in the city, so the city SA1s tended to have bigger populations in them because, like I said, it might be one apartment building that is one SA1. Then that was also associated with having better access. But remoteness, so where you fell on the modified Monash levels, was the strongest predictor of access in the whole model. As we thought it did, it was significant that access improved at modified Monash level 4, which is aligned to that 60-minute jump, but then it declined sharply again after that. So the people that are benefiting most from that 60 jump are the people in modified Monash level 4. And population composition interacted with modified Monash 1 level. So who lives in the SA1, so the types of people. So we modelled it looking at people with the disability, First Nations identification, people, male, female, carers, people with, what did they call them? Long-term illness, they call it in the census. We found that that only mattered in modified Monash 1 for, and only for children and people with a disability. So if you lived in the city and you're in a part of the city that had lots of kids or had lots of people with disability, you actually had lower access to an occupational therapist, which is interesting because they're the most likely people to need an occupational therapist in the city. First Nations people also in the city had very low access to occupational therapists, but that was consistent across most of the modified Monash levels, except for large rural towns, so modified Monash level 3, where it wasn't significant, the number of First Nations people in that particular modified Monash level. So in the city, who lives in the area you live in was aligned with your outcomes, but everywhere else, basically it wasn't. It was about that you were too far away from where it was decided that these services would be placed. So if you're in a remote place with a high population of First Nations people, then you were getting a double whammy in terms of access as well. So what does all of this tell us? It tells us that policy decisions have really big impacts. So especially in rural places, but also in disadvantaged urban places. So half of the 5.7 million people with low, very low or no access actually lived in metropolitan areas, mainly in the low or very low access. And they were in those disadvantaged suburbs that were less likely to have occupational therapists. So the people that are most affected by the decisions in the policy are people who are already significantly disadvantaged. And of course, as I said at the beginning, measurement really matters. So when we measure access properly, we can see different ways that we could reshape geography rather than accepting inequity as inevitable or hiding that inequity. So even with our little, our first study where we just looked at road distance, we only found 500,000 people that were disadvantaged. When we looked at it more holistically, we found 5.7 million people that were disadvantaged in terms of their access to occupational therapy. So it matters. So we have made a lot of recommendations in our report to the SARRAH report, because access to OT services isn't just about numbers, it's about place, it's about people, and it's about how services are funded. And right now, the system works for some communities and it fails others. So we've got some recommendations about how we might fix that. And so the first is to fund the real cost of geography. Travel is part of OT. It's just a thing we have to do. And especially outside of cities, cutting travel reimbursement like they did in the NDIS pricing changes, or choosing not to include travel hits rural and remote communities the hardest, and we were already behind in a lot of ways. So we need budget for real world delivery, not just population side, thinking of things like travel loadings or outreach costs or higher staffing ratios. And we need flexible funding where fee for service just doesn't stack up. So geography matters, and that funding needs to catch up. And we need to take rural and remote workforce shortages seriously. They're not new and they're not random. Entire regions, especially in modified Monash levels 5 to 7, and in the Northern Territory, which, as we said in the report, is one of the hardest hit, have been undersupplied for years. So we're suggesting we need a workforce plan that's focused on underserviced regions. We need to look at building rural pipelines, growing rural origin student enrolments. Go Danielle. Training OTs in rural areas, not just sending them there later. Aligning education with rural health needs and supporting OTs to transition into that rural and remote practice. And critically, we need to recognise rural generalist OT as a legitimate valued career path, reward rural training with real benefits, jobs, recognition, and conditions. Because some of my other research, we've found that people in rural areas are less likely to be in management positions, less likely to be in research positions or training positions. So we need to look at how we can build up those opportunities so that people are inclined to stay in our regions. We want people to stay, so we need to plan and we need to invest in them properly. We also need to back First Nations-led OT service models or really any of our rural service models, because First Nations communities have some of the poorest access in Australia, and this needs Indigenous leadership, not just redistribution. We need to invest in services led by Aboriginal community-controlled health organisations, strengthen the First Nations allied health pipeline. I know that occupational therapy has one of the lowest numbers of First Nations people in our profession, and we need to look really hard at ourselves about how we can fix that. And we need to look at flexible commissioning that supports local governance and culturally grounded care, because we know that access improves when communities lead. And we need to remember the disadvantaged communities, including those in the city, because poor access, it seems, is not just rural. More than half of Australians with low access, as I said, live in the city. So we need to think about targeted incentives for ERSAD decile 1 to 5 communities with maybe wage loadings or higher fee caps or support for people to move into those areas. And we need to look at commissioning services where markets are thin, because we need to step into those places where markets clearly fail. In a lot of places, there is no market. You can't assume there's going to be a market in a place where there's a very small population. So we need to look at minimum service guarantees for remote communities, potentially go back to some of those block-funded multidisciplinary outreach teams for places where we're just not going to get those small, there's not enough to support a single provider in those small communities. And we really need to look at travel and making sure that that people are able to get to these communities and still make a living. We also need to consider cultural safety and building of relationship, because that's so important in our rural communities. So when markets fail, we just have to commission those services. It's essential. And one of my big bugbears is we need to fix the data gaps, because we can't plan for what we can't see. So currently data sets don't tell us enough about the service type, capacity or availability. So this is one step, what we've done, and I'll show you our dashboard very soon, which is another step. But we don't have access to the data about what types of work that those OTs do. The data exists, I know, because I type it in every time that I register, but we can't get access to it. So even though there might be an OT that has the capacity and they're close enough to see you, they may, if they're a geriatric focused OT and you need someone for a child, it's not much use to you anyway. So we need to get that better, more granular data about what it is that people are offering in their occupational therapy service. So we need that still anonymized OT service data from ARPA and the health department. That will help us get real-time national data on workforce capacity. Because if we have better data, we'll make better decisions. And then we need to use access data to drive funding decisions, and we've got the tool here. So using the E2 method gives us a clear, defensible picture of who can actually access services. And if we adopted that health service index, we could use that to prioritize workforce incentives and commissioning and infrastructure investment. And we could report that progress, because equitable access won't happen by accident. It needs intentional funding, planned workforce strategies, community leadership, and data-driven decisions, especially for the communities that have been left behind for the longest. And that means advocacy. So one of the ways that we're trying to support advocacy is building the tools for it. And that includes our interactive OT access dashboard. So this provides the granular data that I've been talking about today, but it's not limited by administrative boundaries. So one of the challenges is we want to measure things in a space. So we want to do it by local government area, or we want to do it by modified Monash area, or maybe a primary health network area. But if we don't, if we just limit our measurement to those areas, it creates artificial boundaries. So someone might live on the edge of that boundary and just travel 20 minutes over that boundary to go and see someone else. But that's not captured if we stick to those boundaries. So by doing a whole national level E2 analysis and then applying the boundaries, which is what we do in our dashboard, you can start to see the differences in the communities, and we can see where the big problems are. So I'm going to stop sharing my slides and jump into the dashboard. So this is the dashboard that we have developed for occupational therapy access. So each of these areas that you can see, I'll start with Australia, actually. Can we go back out? Oh dear, I just opened a new tab by accident. Try again. Come back. There we go. So it opens to Australia conveniently anyway. So each of those little tiny SA1 areas has been mapped onto this map here, which shows us all of Australia. And then we can see what the access is like for all of Australia. And so you can go, oh, actually 1%, that's not too bad, really. Only 1% of Australia don't have access, but then it comes down to who has that access. So over on this side, we can actually look, we can filter to the type of administrative area that we want to look at. So we could just look at New South Wales, for example, and then click on the state. And then we get a different picture. New South Wales is actually better than the national average in terms of no access, but it doesn't have the highest access. It doesn't have as much of the highest access, which I think, yeah, there's Queensland. It's at Brisbane. They have so many OTs. But then we can look at in other ways as well. So the dashboard shows us how the population for each of those areas that we choose. So if I was to choose Macquarie, because it's interesting and I live here, we can look at the local government area data there, and we can say that in the local government area of Port Macquarie, which is got that purple line around the outside of it. There's 86,000 people. 25,000 of them are aged over 65 because we are quite an elderly population here in Port Macquarie. There's 18,000 kids, 4.7 thousand people identify as First Nation, 7.3 thousand people have a disability requiring assistance. So this is from the census. So it's just if the people tick that box on the census, so there may be a few more, a few less. Lots of us have chronic illness, goodness gracious, and we have some unpaid carers, and we have 145 occupational therapists in that area, of which I'm one of them. So 31% of our population have the highest access. Nobody has no access, but there are people with low or very low. Port Macquarie is actually quite well off in OTs. But what's really interesting, so I can pop this, no, normally can pop this map out. It's being rude today. All right. Can you go away now? There you go. So Port Macquarie, like if we scroll right in here, this is the main town of Port Macquarie, and those are our SA1 areas that are marked up on there. You can see that in the center of town, this is where the highest access is with our dark blue, and it gets a bit lighter blue as we get further out, and then we get into our low area over here on around Rawdon Island. But interestingly, it jumps up again over here into these, what we would consider the sticks areas of Port Macquarie. And the reason it does that is because this is where that level 3 to level 4 change happens. So you can suddenly, you've got 60 minutes of travel into these particular SA1s. And we've got OTs that are working in Port Macquarie, we've got OTs that are working in Wauchope, and we've got some up here in Kempsey. Where's Kempsey? A bit further north. Who can all, I've lost Kempsey, there it is, up in Kempsey, who can all access this place within 60 minutes. So all of a sudden, this area has lots of access, whereas these areas don't. Even Kempsey itself has lower access because it's a MMM3 again. So it shows that these decisions that are made at a policy level that seem like relatively sensible can have unintended consequences for the people that live there. And you can also jump around and look within here and go, what does my place look like? So you can go here. I'm not going to type my address in, but you can type an address in here and it will take you to your house, and you'll be able to see what level of access just by looking at the colors on the map that you have in your area. So we very deliberately included the types of administrative areas that people would be most likely to be interested in, including the electorates. So if you wanted to look at the electorate of Cowper, which is the electorate that Port Macquarie is in. Oh, it's being difficult today. Sometimes when your kids are watching Netflix, it doesn't put up all the data because it gets tired, getting cross. But you can actually go to our local member and say, hello, this is what it is. This is what our distribution is in our area for the 166,000 people in Cowper. I'll just reset that one so it stops looking at it. And then when you jump around, it will take you to different areas. Bennelong, let's look at Bennelong. So it has lots of access in Bennelong, which is down here in Canberra. Come on, Bennelong. So the idea with this dashboard is just to let people jump around, have a look, get involved, and be able to look from a policy perspective. If I'm working for a primary health network, and I want to know what's happening in Brisbane North, it can tell me that in Brisbane North, we've got some areas with low access, and we can start to look at where those areas are. So that helps us to plan where do we need to look at deploying more OTs in that space. Hopefully in the long run, I'll come up with a model to tell us where we should put those OTs. But that's the next plan. That's not for today. So popping back into the presentation. That is our dashboard, and I'll put the link up in a minute for people if they want to go and have a look. So where to from here? We want to expand the website. So we want to get make it more like an observatory of all the registered health professions and be able to do that over time. So have different years that people can click through. Of course, that's going to require funding, because if we're looking at a $2,000 cost from AHPRA to get that data, or it's $2,000 per profession per date, then that adds up very quickly when I think we've got 16 registered professions in Australia. And that doesn't include the unregistered professions like speech therapy or social work, who we don't have data for at all. So we're actively seeking partnerships and to look for funding to continue to expand the dashboard so that we can put that, that data out there for all the professions that we can. I've got some publications underway. So the regression results against the E2 we've sent into Health and Place, and hopefully we'll find out that they're going to accept that soon. Never know. And I'm also writing my PhD thesis, which takes us through from spatial analysis, spatial justice, right through different ways of measuring things to help us achieve that outcome. I'm also looking at links between access and infrastructure, because just looking at the maps, it looks like where there are campuses that teach occupational therapy in rural areas, there's higher numbers of occupational therapists, which would make intrinsic sense, but we'd like to prove it. And then, of course, the location modelling, so that we can say if we get more OTs in this spot, then we will improve access in this area. And maybe even influence policy a little bit to say some of your arbitrary decisions like 30 minutes, 60 minutes are actually causing more problems than they're solving. So thank you, Sarah, for funding the AHPRA data and providing the opportunity for me to present at this webinar. It's been great working with you. And I'd like to open the floor to any questions. Oh, there's much silence.
I was trying to find my mouse. Hello, Karen, too technically challenged at this time of night. As you can see, I'm Kirsty Pope from Monash University, Department of Occupational Therapy, Peninsula Campus. So I'm also like, wow, amazing. This is just fantastic. And I think, but there's some things you've said and I've gone, seriously, you have to pay $2,000 to get our own data about our own workforce. How the hell does that happen? And that's just criminal. I didn't even know that happened.
After we've spent $120 putting it in. So
Yeah.
that's even better. So anyhow, it's a cost recovery, apparently.
Oh, because it costs them a lot, does it, for us to fill in our... Anyway, I won't go down that road. I think we all know where we're going for that one. And then just when we talk about the workforce data, I was thinking, I think you probably made this point. You were saying about how many OTs there are and registered in the area, but one of them, for instance, could be me, and I actually don't work clinically. I don't offer any services.
Yep.
So that's what you're saying. It's actually not showing. The access is probably worse, isn't it? Because we can't take that into account.
Probably, because yeah, I haven't worked clinically for over 8 years. So
Yeah.
I'm not much use to you, really,
No.
if you need an occupational therapist in a hurry.
Yeah.
So having that level of granular data would be good. And we could make some inferences potentially, because we can get the data, and I have published an analysis of from 2013 to 2021, how many OTs there are, what types of work they're doing, because we do fill in that survey. What we can't do is link that data to where they are. So I can do it by modified Monash level. I think I could do it down to local government area level, but local government areas are huge rurally. I can do it by postcode, but half of the Northern Territory is one postcode.
Yeah. It's not really telling
So
you very
that,
much, is it?
no. So whereas at least knowing which town they're in gives me a better chance to actually float something that's fairly reasonable, in terms of where someone is. But street level access would be, I mean, most of us are services are advertised, so it's interesting that we can't
And yes, do the
closer than that.
results. Yeah.
But
I could probably talk to you all night, and I don't want to dominate if people have questions, but if I can just ask you one more thing, I think. I'm about to finish my PhD as well. So, and one of the things I'm doing is mine is about placement capacity for occupational therapists and looking from an organizational point of view. And from all my research, I'm then putting together a framework of, if we were doing this from scratch, what would the system look like? And funnily enough, at the very top is, oh, can we have a national allied health workforce strategy, which we do have a draft of now. But one of the things they say is that we need accurate data. So everything you were just saying there, I was thinking, yeah, I've written that too. So, and I'm wondering, like, because otherwise there's no point. And we know that there's data sets out there, they don't connect, they don't really tell us what we want them to tell us. It's very dominated around a medically nursing orientated. Allied health is huge. So who are we looking at? All those kind of things. But I'm interested around advocacy, and I just wondered around what would be are you thinking around how we can advocate, through the association or chief allied health officers, or, any thoughts around that, about any recommendations for meaningful advocacy?
yeah, I mean, my approach has been show what we can do with what we have so far, and say, look, if you wanted to be more sharey, we could actually do more than that. Because I think sometimes things get a bit stuck in terms of, like, we've had those fact sheets come out for years of how many OTs there are in Australia and things like that, but they don't really tell you much.
No.
Beyond the overall state of the profession. So this is an attempt to say, hey, look, there's other options that we have to look at the way services are distributed, and being able to get a little bit of extra data would make that even more powerful as well. And we could still do it in a way that doesn't compromise the privacy of anyone involved, because I don't want to do that. No one wants to do that. We want to be able to make good decisions around what can be done. And so starting to push that. And I've started sort of getting some comments from other professional groups that are interested in doing something similar for their professions. And if we can start to build up a bit of momentum around that, I think that could help a lot with our advocacy.
Yeah, great. Thank you. Thanks very much.
It's okay. Are there any other questions?
Karen, I was just going to wonder whether people might actually be interested to understand a little bit more about spatial justice as a concept, because we talk a lot about occupational justice, and there's some nice alignment, but it's looking at very much the environmental aspect, and and how all the work you're doing feeds really is inspired by, I guess, your passion and quest for spatial justice for OT clients. And there might also be some commentary that you might want to add around how relevant these methods are for other health professions, other allied health professions as well.
Yeah, absolutely. So spatial justice is something that you'd relate to this, Kirsty, where you stumble upon something while you're reading, getting ready to start your PhD. It was something that I found in the geography literature, and like occupational justice, spatial justice is geography's version of that. And it's about, from a geographer's perspective, there's no experience of justice that isn't place-based. Everything is related to where you come from and what is happening around you. And so I took that concept of spatial justice and I applied it to with Lefebvre. It's French. I always have to think about how I say his name. Lefebvre has this beautiful model where he talks about the way that we shape geography, because humans have been shaping geography for millennia to make our lives easier. And so spatial justice comes from the idea that we decide how we shape our geography and we decide where we're going to put things. And the majority of the time in the last sort of 100 years or so, that has become the city. And so all the really good stuff, which is really community property, is in the center of the city. So all the public hospitals, all the really big public libraries, all those lovely public open spaces, things like that are in the city. And we can actually intentionally or unintentionally keep people out of those spaces. So we can decide to put a road toll on, which means that people from the country or people from the western suburbs can't get in to the city without paying extra. We can because those things are all there, it makes the property values in those places very expensive, so only very wealthy people can afford to live there. And so if you need access to those things, it can become unjust for you to be able to try and get hold of those things because they're all sort of in this one space. And then we can kind of look at the way we measure those things. And so conceived space is the first thing that Lefebvre talks about. And that's where most of my focus has been, is how do we conceive of spaces and understand them? What are the borders? What are the restrictions that we've put up about the way that we think about spaces? And how does that influence someone's experience of justice? So that's why I've been looking at different ways of measuring access. And the other issue can be perceived space. So how do we think about other spaces? So Australia, you know, the rest of the world seems to think we're all blonde surfers, and everything's just like it is on Home and Away or something like that. And so that's a perception of Australia that some of us have internalized as well. And so, but there are also places that, oh, I would never live there. That's, you know, for whatever perceptual reason, or that's a desirable place to live. And so those perceptions can influence what we give places and what we don't give places. And then there's the lived experience of the people in that place, which is the hardest thing to measure because everyone's lived experience is different and their relationship to that place is different. But it's why we get sad when things happen in our places that we didn't want to happen, or excited when things do happen that we wanted to happen, in terms of the way we shape geography. And so influencing all of those things can change the way that we understand who's deserving, who's not deserving, what places should get things, what places don't get things, who's allowed in, who's not allowed in. And that makes all feeds into a single person's experience of justice. So spatial justice is about how do we influence those things particularly, you've probably heard of Rawls' version of justice. So like the blind justice, where if you were setting up a system and you didn't know where you would end up falling in that system, how would you set that system up? So you could end up on the northern beaches of Sydney, or you could end up in Campbelltown. How do we make it so that it's even, so that everyone has the same opportunities regardless of where you end up? And so that's where I'm coming from, is how do we make this more spatially just, but particularly for rural people, because we know that rural people are dying younger and are sicker and are having less access to health services despite the fact that they need them more. So spatial justice, that's where I'm coming from. In terms of other professions, all this comes down to is access to data. If we can get the data, which we can purchase from ARPA if we have the funding, then we can do this for any registered profession, because ARPA obviously only hold data on the registered professions. So we could do the same thing for medicine or nursing or physio or anyone who's registered, and we could map this out. And that would be really interesting, because then we could look at ways we could combine that data to go, well, you know, maybe you don't have this kind of professional, but you do have a few of these professionals. Maybe we can do some task shifting or something like that in some of those places. But again, it's all about data sharing, and data access is the limitation at the moment. Does that answer your question, Roz?
Yeah, I think it's so important that this data seems buried, inaccessible, very difficult, and that in and of itself is not allowing you to answer questions that you're asking very easily. So I think it's been a really interesting process for me, as well as one of the supervisors, to understand just how difficult it has been for Karen to access data that we would have all, you know, like Kirsty said, we would have just assumed that was available. And then it was like, well, it's going to cost this amount of money. And SARRAH, thankfully, were able to fund it. And then I think it's very interesting that people are asking for information and workforce planning and all of these types of things. But even the challenges that you've faced in different departments talking to each other and being willing to release data, that was a bit of an eye-opener as well. So there needs to be some much more support put behind all of the allied health professions in particular to really understand this information.
Yeah, it frustrates me because I know the data's there. I know the data exists. And if we could get hold of the data, we could help make much more useful decisions about where to deploy staff. We could help companies even decide where they wanted to set up their next outpost of their company. But if we don't have the data, we can't help make those decisions.
I try not to be too negative and political, but I think for me, one of the reasons it doesn't change is because people making policies sit nicely in all those areas. Thank you very much. And I can easily access everyone I want. It's not an everyday problem for them, you know, and I think that's one of the issues. It's hard, isn't it? And you'll see that when a leader happens to have a relative who's disabled, or happens to, suddenly this is the new thing that we're all interested in. So I think it's shame, but I think for me what's amazing is to know that the works like SARRAH and others, and the work you're doing, is that we have to just keep chipping away at that, and like say, if in numbers, to kind of keep saying we're all trying to say the same thing here. And I hear a lot in Commonwealth talking about, you know, we've got this issue, we need to address it. Okay, well, we're telling you, if you just put your money there rather than over there, then we could maybe move that. So fascinating. And as an occupational therapist, I love that the justice. I think the spatial justice, because for me, we teach our students obviously about the new CAMMOP model, the Canadian model of performance, and I think that really helps to students to think about this is much bigger and wider than we tend to think in very clinical sense. And I've been in Australia for 12 years nearly this year, and I live in Frankston. Everyone went, oh, you're living in Frankston. I said, what's wrong with Frankston? It's by the sea and I've got palm trees. It looks really nice to me. And everyone's worrying. And like you said, that perception. And I said, well,
Yeah.
you've clearly never been to an inner city in the UK, have you? Because Frankston looks great, if you're asking me. So I think that's right. It influences, and I see the negative image that Frankston has and how that affects funding or change. So fascinating, Karen. I could speak to you all day, but I'll stop. So
Oh,
thank you.
we'll make your time.
Yes, we will. Yeah, thank you.
Kat.
Oh, thank you. I just wanted to make a couple of comments. So one is, yes, that comment about having bureaucrats require some of these services is a real thing. The last time we went to visit our friends at the Department of Health, Disability and Aging, somebody had had an injury to their wrist, and they knew all about physiotherapy and how great physios were. How the initial diagnosis was wrong and the physio got it right. And anyway, so it's a thing. But I just want to make a couple of points here. One is that the data set, all we funded was the data set, right? I just wanted to make that really clear. So we found $2,500 in our budget, which we don't have any funding, right? So we don't get government funding, we don't get peak body funding. We are cobbling bits and pieces together at the moment to keep the doors open and the lights on. So $2,500 though for this important piece of work was something that we saw as absolutely essential. And it's going to help support, all of our submissions to government on various inquiries and committees and consultation processes, for the foreseeable future. So I did, put a couple of examples of that in the chat so that people can have a look at that later. But the other point that I wanted to make is this stuff is freely accessible and we want people to use it. So I guess, if there was something you could do here, the call to action for the people in this meeting here is to talk about this data set and make sure that people know where to find it, because the ability to be able to go to your local member of parliament with data that is to their electorate, that's powerful stuff. They're going to sit up and take notice, especially if you're there explaining, what this means for your constituents. So please take this information, share it broadly, and have a go at using it, for these sorts of things. I love the fact that you can map to a primary health network, because primary health networks, as commissioners of services, will be very interested in this data. And because SARRAH is so tiny at the moment, we're a micro organisation, we haven't got the capacity to get out there and talk to everybody. So we really need everybody to get out there and do that talking for us. So this is a really powerful tool, and I just hope that people are going to kind of pick it up and run at it, run with it at speed. So thanks, Karen. It's a brilliant piece of work.
Thank you. Thank you. It's been really good to work with SARRAH, and it's been really good to be able to see this little dream of mine come to fruition and go, hey, look, this is a real thing that we really can do, and we can hopefully make some better decisions for Australians to be able to access the help that they need.
Definitely. Well done. Amazing.
A little dream. Thanks, Tracy. That's very kind. So I think that's all I have to say. Does anyone else have any other questions?
Keep going, Karen.
Wonderful.
Thanks, Christy.
Cunnamulla's
I'll take
lovely.
over the world one day.
One data set at a time.
One data set at a time. It'll be 150.
Well, what are you waiting for?
Finally.
You're waiting for next census, aren't you?
I was
as
going to
well?
say census this year.
Yep. I think it's the 14th of August. I'm waiting with bated breath, but it'll be 12 months before most of those results, like the initial results, are released, and then maybe even a little bit longer for some of the more juicier ones that I'm interested in.
And
So,
and the issue is that decisions have already been made, and there's some big assumptions that underpin some of those. So if you've been following the NDIS reforms and some of Mark Butler's interviews over the past week or so, there's this big assumption that if they're going to start to reduce the growth in the NDIS and displace workforce, because they're openly acknowledging that allied health workers particularly will be displaced, that they're all going to go back to health, or they're all going to go into aged care. So I just wonder what the universities are thinking about those assumptions, and where the interest of our undergraduates are, and how they're going to be prepared for rapidly evolving workplace when they do graduate. So whether it's this census data set or the last one, we know that the data hasn't shifted much. You can go onto the ABS website and have a look at health workforce data that shows basically all of the growth that you see. The aggregated growth in allied health workforce has been in modified Monash 1, and it's been flatlining everywhere else. So I don't think we're going to see a big shift, because we haven't seen any policy changes that would support a change.
Correct. Yeah, people aren't going to go, hey, I'm just going to up 6 from the metro area and I think I'll go. There has to be some incentives for that, or and there's a whole load of things going on there. But a little plug for us at Monash that I'm project leading a new degree that will start in 2027, which is similar to the Flinders Uni one for the 3 rural locations. So we'll have that in Mildura, Bairnsdale and Wonthaggi, and make sure 80% of those students are from that area. So we're looking excited about that.
That's really exciting.
And that's where this data would be so useful, to be able to go, where should we be targeting?
I think that's a good point, because of course we're trying to tackle the, where do you saturate your market? Do you have an intake every year and there's so many people? So, and is it a model then you can move around? So absolutely, that's a great point, Karen, about using this modelling to go, that's where we could go. Oh, there.
And and when we get to look at the next census data, have a look at those locations where Flinders course has been running for a few years. See if there's been any shift in population demographics for OTs there.
Good point.
They're tiny numbers at this point, but
they are. They're similar, aren't they, to us and all. But it'd be good. Well, and Flinders used the example, I think, where the speech pathology student has said it's quicker for me to train to be a speech pathologist to help my child who needs one than it is to wait for a speech pathologist to come and to live here and work. So she has no access to speech pathologist. She said, I'll just train to be one. It's quicker. And you just, I'm laughing, but it's not funny. And you just think it speaks volumes. So
And as Tracy has said in the chat, she's having some tech issues, looking at the UDRHs and really looking at how we can link in with our UDRHs to also build that workforce. And so, some of the research that I'm still crunching the data on includes the UDRH locations, the university locations, those kinds of things, to see how is that influencing.
Trace was saying the Irish it is, and it's an interesting. It will be interesting to see how that comes out, Tracy. And for me, trying to look at the project of setting up the new degree just highlights what we all know here. The Commonwealth supports a whole load of things, but it supports this here, and here, and doesn't join any of it together. And I was going, I'm actually not asking you for any more money at this point. What I'd like you to think about is, how could, like you're saying, how can we join some of this together and get more bang for our buck? That would be good.
Exactly.
But it's like every other government kind of department that we need to quickly look like we're doing something. We'll quickly go and get that data. Doesn't matter, that doesn't really tell us anything properly. We'll make a decision, and it's just that it's frustrating, as you say, Karen, because you know that at the end of the day, people who need things the most are disadvantaged. So
yeah, and it's important to remember that our modified Monash level 1, so our cities, covers 0.26% of Australia. So it's a tiny fraction of Australia. It does admittedly have 72% of Australians living in them, but it's a tiny fraction of Australia in terms of space. And so while the majority of your votes live in that 0.26% of Australia, there's still a huge bunch of us who don't. And you need us here. The cities need us to be in the rural places if we want to eat. If in Port Macquarie's case, you want somewhere to go on holidays, well, you're going to need someone to run the hotel. If, it's a reciprocal relationship, and that's often forgotten. It's assumed that we're sitting out here for no reason other than our preferred lifestyle, which, to be fair, that's why I like Port Macquarie.
I do believe that Tony Abbott once, didn't he say something
Yeah.
like it's a lifestyle choice? Oh,
it's a lifestyle choice to live in a Aboriginal community on country that your family's lived in for hundreds of thousands of years. Yeah, absolutely.
Yeah. And one of the things that we're doing, so you talk about perception, it's interesting because the work we're doing with our Monash School of Rural Health on the courses is to change that perception where it's a negative view of regional and rural and communities, all those poor people out there, like no, these are great places to be, and actually we should be porous in metro kind of thing. And like so some of it's trying to change that rhetoric, isn't it, and that perception, as you were saying, around and it should be reciprocal. So interesting.
Yeah, absolutely. So yeah, we're here for a reason. And we need access to services as much as anybody else. And we used to have them. It used to post-war, when they were trying to build up the cities like Bendigo and Albury and places like that, it was considered completely normal to give money to rural places and give more money, because obviously they're going to need more because they have to drive further. It's an inconvenience that we need to offset. But as neoliberalism has rolled through, it's like, well, actually, no, you're a problem for us.
Yes.
Here in the city. So
you're not supposed to eat food or have, any clothes on.
Don't need any of those things, Christy.
You don't need any of those things at all. Like that's my home base of St. George. That's primarily farming.
Yeah, which is the reason that, and the National National Rural Health Alliance often put forward, most of Australia's gross domestic product comes from rural places. So can we have some of that back in terms of services, please?
Very good point.
Which is a fair and reasonable suggestion, I think. Yeah.
Amazing. I'm definitely going to share with all my colleagues actually your amazing dashboard, and so I do that. Happy for me to put it on LinkedIn and put it all through.
Please,
just do all those.
Please do.
Have you put it on LinkedIn or anything, and I can relink, or I'll do it as well? I don't know whether.
I've put it on LinkedIn probably about 3 or 4 weeks ago.
Okay, I can also then find you and do that. So because I like that. I like it for me. Definitely is coming into my teaching with students. I teach a unit about population-based teaching, and we do CAMMOP and those kind of things. So I think it adds a depth to that, which would be amazing. But with my colleagues sharing and helping, we've got people obviously working advocacy roles. And then, like you say, each person being able to then take that to their state member of parliament or somewhere, or a local, whatever, and say, so thank you. Yeah, that will be my action from today. Thanks.
That would be wonderful if we could all do that.
Mm.
Definitely.
Okay. So thank you, Karen. We might wrap it up there. I'll um, I'll just take a moment because I failed to mention earlier, we funded a tiny portion of this. The rest of it came from CSU's resources and with the support of Western Sydney University. So thank you so much for creating the space that enables this work to happen. Really appreciate it. So thank you, everybody, for a fantastic discussion. Thank you, Karen, for some wonderful work. Please go forth and distribute, and yeah, keep following us. Keep following us along.
Yeah. Thanks, everyone.
See
Thanks,
you in Coffs
everyone.
Harbour for our conference in November.
Definitely.
See you.
Okay.
Have a good night.
Thanks, everyone.
Karen.
Bye.
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 Bye.